Welcome everybody to today's webinar on diagnosis and treatment of rebound intracranial hypertension. First of all, a very big thank you to the Spinal CSF League Canada organization for organizing this wonderful event. It's always good and very important to raise more importance and ideas about this topic. I am Dr. Yasmin Hoydongs. I'm a craniofacial pain specialist at the University of Toronto, and it's my pleasure to introduce the two panelists of today's webinar. We see on the left Dr. Kranz from Duke University, who holds the position of Associate Professor of Radiology, and he is the Division Chief of Neuroradiology at the Duke University Medical Center. He has extensive clinical and research experience in the diagnosis and treatment of spinal CSF leak, including expertise in clinical management, imaging, treatment, and post-treatment considerations. He has authored or co-authored 70 manuscripts in the peer-reviewed medical literature with a focus on SIH and image-guided spine procedures. After completing his undergraduate education at Georgetown University, he earned his medical degree from the University of North Carolina at Chapel Hill. He completed a residency in neuroradiology at Duke University Medical Center and has served as faculty at this university since 2009. Our second panelist is Dr. James Kahn, who is assistant professor and clinician scientist in the Department of Anesthesia and Pain Medicine at the University of Toronto. He completed his anesthesia residency training at the University of Toronto and fellowship training in pain medicine at Stanford University, where he worked closely with Dr. Ian Carroll at the Stanford CSF Leak Clinic. He holds a Master of Science in Clinical Epidemiology from McMaster University and has published over 45 peer-reviewed articles. He serves currently as a research lead for the Division of Pain Medicine at University of Toronto. It's my pleasure to give the floor in a minute to Dr. Kranz, who is going to present to you today about the diagnosis and treatment of rebound intracranial hypertension. This presentation will be followed by a Q&A. Please put questions, all your questions you would like to ask the panelists after this presentation in the chat box. However, please be aware we will not be addressing any personal questions or we can give any personal medical advice. Dr. Kranz, big thank you again for attending, Dr. Kahn as well, and I give the floor to Dr. Kranz for his presentation. Thank you.
Thank you very much. I'm going to share my talk. Are you able to see the slides okay?
Yes, we do. Thank you.
Okay. So thank you very much, and thank you to Spinal CSF League Canada for putting on this webinar. I think this is a really important and a much under-recognized facet of a disease that itself is much under-recognized, and so having the opportunity to talk about rebound intracranial hypertension, I think, is really important. And so hopefully we'll have a chance to talk about what I think are some of the basics of this condition, and then during the panel discussion have a chance to sort of get into a little bit more of the nitty-gritty, the advanced details, if we have time. So just by way of disclosure, I am a member of the Medical Advisory Board for Spinal CSF League Canada and for Spinal CSF League Foundation in the US. I do, again, want to emphasize that no part of this presentation should be construed to represent medical advice to any individual person. There's a lot of nuance and personal details that go into making medical decisions, and so that should always happen under the auspices of an established physician-patient relationship. And also, we're going to be discussing the most common presentation symptoms and course of rebound intracranial hypertension. But I'm cognizant of the fact that there are variations and they do exist, and not all cases will meet these generalizations. So the point of this talk is really to give people broad familiarity with the condition, talk about what happens in most cases, but I do recognize that people will vary from those generalizations. So by way of overview, we're going to try to address 4 questions in the next 25 or 30 minutes or so, leaving us sample time for question and answer. So first, we're going to talk about what is rebound intracranial hypertension, how do we recognize it, what are the common features. Then we're going to talk about how often it happens, and based on our experience here at Duke and some available literature, we're going to briefly entertain the question of why does it happen, which is a question that probably has more unanswered questions than it does have answers. And then finally, we're going to talk about how in general we treat rebound intracranial hypertension and what my sort of basic algorithm is for treating it. So getting started, what is rebound intracranial hypertension? Well, this is a type of headache that occurs after treatment for or sealing of a spinal CSF leak. And it can occur with any treatment type. So originally this was recognized with regard to epidural blood patching. And all of the initial descriptions and our experience with this condition really came out of observing the phenomenon after epidural blood patching. But since that time, we've also recognized that it occurs after surgery for CSF leaks, and with newer techniques such as venous embolization, which is a technique that's used for treating a particular type of CSF leak called CSF venous fistulas. And I think one of the hallmarks of this condition is that the symptoms often seem different than the symptoms that people have when they're leaking. And it was really that change that I think prompted initial recognition of this condition. And so we're going to try to focus on a couple of things that in broad strokes help differentiate leak symptoms from rebound high pressure symptoms. So I should also say that I by no means was the first person to describe this condition. This is something like a lot of this work that was initially reported by Dr. Bahram Mokri, who was at Mayo Clinic, and he was really the father of this this now emerging field in spinal CSF leak. This was a paper from 2002 that he wrote talking about intracranial hypertension after CSF leaks in 4 patients. But I think since that time, we've started to recognize this a bit more broadly. But I do want to recognize Dr. Mokri because a lot of the work and a lot of the understanding that we have dates back to his original observations. So what are the common symptoms? Well, we all know that in the setting of spontaneous intracranial hypotension with CSF leaks, that the stereotypical headache is one that is orthostatic, meaning it's worse when you stand up and gets better when you lay down. We also know that not all cases of CSF leak have that same relationship, but in general, probably about 80 or 85% of cases do have at least some orthostatic component to it. And after treatment, we see in some patients a change in that relationship to headaches that are worse when lying down. So sort of the opposite of the orthostatic headaches that people experience while they're leaking. Or in some cases lose their positional dependency altogether. So some people will notice that that their headache is not worse when laying up or when standing up, and not worse when laying down. It just seems to have lost its positional component altogether. So from a schematic standpoint, I often think of spontaneous intracranial hypotension as being, worse when upright and rebound worse when laying down. And as a result, this tends to be a phenomenon that people will notice when they first wake up in the morning, or when they try to lay down during the day, if they're recovering from an epidural blood patch or recovering from treatment, because once you've been laying down for a long period of time, the intracranial pressure will go up. There's oftentimes a change in where people experience their headaches. And again, we can speak in generalities, recognizing that not everybody, has the same experience in terms of their headache pain. But I would say that more than half of patients who develop rebound high pressure notice a shift. And that shift is typically from sort of the back of their head, upper neck, occiput region, where headaches are very common in CSF leak, to more of a frontal type pattern, oftentimes periorbital in location around the eyes. And oftentimes people will say to me that they feel like it's in their eyes or deep behind their eyes. And that description is a very common one. Sometimes this is experienced less in sort of a regional involvement around the eyes and face, but more sort of a whole head pressure, holocephalic headaches that just feel, people often say that they feel like their head is a balloon that's overinflated. So that's another common description I hear of rebound intracranial hypertension. There are some common associated symptoms. So vision change, often in the form of blurry vision, is something that a lot of people will tend to report with rebound. In the early stages, nausea in particular is very common. It's one of the more common symptoms that we see. And fatigue. Fatigue can be present in a variety of longstanding headache conditions. We see it in patients who have CSF leaks, but sometimes people who don't necessarily have a lot of fatigue before treatment will develop new fatigue after treatment with regard to rebound high pressure. Most of the time when we see this phenomenon, it's in the first 24 hours after treatment. Most commonly, I would say this is the evening of the procedure. So I typically tell people that, they're going to go home, and usually towards the end of the day, around the time that they get ready to go to bed, that's when we most commonly start to see onset of these symptoms. Sometimes it occurs in the middle of the night, and sometimes people wake up the next morning with headache. Again, there is some variation to that. We're going to talk about what our data would say about when the onset of the symptoms are. But I will say that, I've had some patients who experience onset of headache immediately, sometimes during the epidural patching procedure. We've even had to, administer IV treatments for rebound high pressure, while the patient is still on the procedure table getting their epidural blood patch. That's not typical, but it does happen in some uncommon cases. So one of the most common questions that I get when I'm talking to people about rebound high pressure before blood patching is how long does it last? And again, there's quite a bit of variability with this, but most of the time, these cases will resolve within 5 to 7 days after the first week after patching. And for the most part, when people experience rebound high pressure, they'll feel it most intensely the evening of the procedure. And then usually by the end of the next day, the rebound high pressure symptoms are waning. They're on the decrease, and usually by 2 or 3 days after the procedure, those symptoms are decreasing. Again, with notable exceptions. There are some patients who experience symptoms for much longer. Sometimes we see this for weeks after the procedure, and occasionally even months after the procedure. So I think it's important that before doing any intervention for a CSF leak, these are important things to talk about in terms of what to expect after the procedure. So I want to get into a little bit more of the details about how often this happens. So just as a point of warning, we're going to have a lot of numbers coming up in this section. So if you're the kind of person who likes a lot of data, this is the section 2 is the section for you. So we looked at this question. So we looked at 109 people who had first-time epidural blood patches and 40 people who had repeat epidural blood patches. And this is for a variety of different conditions. This included people who had spontaneous CSF leaks, some people who had post-dural puncture headache, although fewer people with post-dural puncture headache than spontaneous leaks, and even some people who had orthostatic headache who ultimately did not go on to have a diagnosis of CSF leak, but where we were trying epidural blood patches as sort of empiric therapy for orthostatic headache. And what I did is I call all these folks the first day after their epidural blood patch. So these are rates measured the day after the procedure, which is an important detail, and it affects how we report these numbers. So for all people, all comers getting an epidural blood patch, what we found was that 53% of people had a rebound intracranial hypertension. And again, this is defined by a change in headache phenotype to one of those descriptors that I talked about, where it either lost its positional component or was worse with laying down, oftentimes with a shift of location. Now, of the people who had rebound high pressure, so of this 53% of patients, the majority, over half, 58%, had mild symptoms. And by mild, I mean a headache intensity of between 1 and 4 on a scale of 0 to 10. And these are patients who generally require no treatment. They just have mild headache. It tapers off pretty quickly, and don't need to go on to any additional steps. Of that 53%, 34% or about a third of the people who developed rebound high pressure had what we would consider moderate high pressure. And moderate means that we had to start an additional medication for it. So these are people with headache severity of 5, 6, 7, 8, 9. And then severe or 10 out of 10 headache was 9%. So about 1 in 10 people who develops rebound high pressure will have experienced that to be severe. And we'll talk in a few minutes a little bit more about how we generally treat people in these different categories. For people who had repeat epidural blood patches as opposed to a first-time epidural blood patch, the rate of rebound high pressure was pretty similar, 52%. So again, about half of all people. If you take all people who developed rebound high pressure, only 21% of them required treatment. So what I tell people, when I'm talking about rebound high pressure is that mild rebound high pressure symptoms are actually quite common, and most of the time we don't need to do anything to treat them. But we do have treatments available for those who require it. We also found that the type of CSF leak affects the severity and also the frequency to a small extent. So there's a type of CSF leak called a CSF venous fistula, where you don't have a fluid leaking into the space around your spine, but rather it is leaking directly into a vein, and it gets siphoned off and returns to the systemic circulation. This is a very important type of CSF leak that we have found out about in the last few years. And folks with CSF venous fistulas tend to have slightly more severe rebound symptoms and slightly more common rebound symptoms. Another question that I'm asked very frequently is, can you get rebound high pressure if you have no definite leak? And the answer to that is yes, you can. There's something just involved with just doing the epidural blood patch alone that can precipitate rebound high pressure symptoms. So to that point, if we looked at people who had a definite leak of epidural fluid, it was 53% of those patients developed rebound high pressure. If you had a CSF venous fistula, you were a higher chance, about 69%. So about 2/3 of people with CSF venous fistulas developed high pressure. If you had orthostatic headache, but ultimately went on to have another diagnosis, whether that was POTS or cervicogenic headache or other conditions, we still found that about half of those patients undergoing blood patch had a rebound high pressure symptoms. So what does this mean? It means that from a diagnostic standpoint, whether or not patients develop rebound high pressure, it's not particularly useful from a diagnostic standpoint. And also that people who get epidural blood patches for a variety of different conditions, whether that's post-dural puncture headache or spontaneous CSF leaks, are all at risk to some degree for rebound high pressure. Now, the group at Cedars-Sinai, Dr. Shevink, looked at this question as well. They defined the question a little bit differently. So they defined rebound high pressure as a headache basically requiring a medical treatment. So their threshold was a little bit higher. These are people that I would consider to be sort of moderate or greater rebound high pressure. And so their numbers are going to look a little different at first, but you'll see that they're not really all that different. So they diagnosed rebound high pressure in about 27% of their patients. So again, about a quarter of patients, which if you look at the group of patients that required treatment in our study, it's pretty similar, 21% versus 27%. So many patients, again, will not need treatment. They followed patients out a little bit longer, so they have a little bit more detail about when the onset is. They found that within the first 72 hours, it was about 74%. At 3 to 7 days, it was 22%, so about a quarter of patients, or 1 in 5 patients. And then a very small percent, but important percent, developed symptoms beyond a week and up to a month. So 6% of those patients. They looked at patients in terms of how often their symptoms resolved, and found that by 3 months, 94% of these patients who had moderate or greater rebound high pressure had resolved. They, for those physicians who are wondering about whether or not papilledema is present, it was present only in the minority of patients, or 2 out of 25 patients in their study. And for those patients who may be on the webinar and wondering what papilledema is, this is a swelling that we can see at the back of the eye when you do an eye exam, and it's one of the ways in which high intracranial pressure can be diagnosed. It's not present in all patients who have high intracranial pressure, but it is present in some. So I guess the take-home message from that is that sometimes people will have an eye exam and not have papilledema and get told, well, you can't have rebound high pressure, and that does not seem to be a true statement based on this data. So in summary, for this section, I would say about half the people who get a patch will develop some degree of rebound high pressure, regardless of why they're patched. but most cases are mild and require no treatment. I think it's a good idea for people to be aware that this can happen, and so they're not surprised when they develop some rebound high pressure symptoms. Most cases, the vast majority of cases, at least in my experience, start within the first 24 hours, but uncommonly, we can see some cases develop a little further out. And the large majority of cases will resolve within several weeks or up to a couple months at most, with a very small minority of patients persisting even beyond several months. So this next section, why does it happen? The answer is we don't know for sure. I mean, that's the truth. I think it's very important to be upfront about what things we know and what things we don't know. And we don't really know exactly what are the mechanisms that lead to rebound intracranial hypertension, so why it's happening in half of patients, we don't know for sure. There are a couple of possibilities, and these are theories, I should say, that I'll mention. The first is that when you do an epidural blood patch, you're putting blood into a confined space around the spinal thecal sac, which is the sac that holds the spinal cord and fluid. And it creates a squeeze on the thecal sac. And you can sort of envision sort of a blood pressure cuff inflating around your thecal sac. And what that does is it's going to push fluid out of your spinal region and up into your head. And it's also going to make that whole system a little stiffer, so that when you stand upright, it has less elasticity to sort of accommodate the spinal fluid that wants to flow downward into your spinal canal. And that makes the whole system a little more rigid. And it also increases the pressure up in your head. I always sort of envision, you know, those folks who tie the balloon animals, and they have these balloons that are slightly underinflated, and it doesn't matter where you squeeze that balloon, it increases the pressure in the rest of the balloon. It's very similar analogy when we're talking about doing an epidural blood patch. So increased stiffness is one possibility. The other possibility that we talk about is that sealing a leak causes an imbalance, and that, you know, your body is trying to compensate for losing spinal fluid by generating more spinal fluid. And when you abruptly shut off the leak, you now have a situation where you're producing too much and not reabsorbing enough, and the pressure goes up. These sorts of phenomenon are the sort of thing that we would expect to see for as long as blood stays in the epidural space, which is typically up to about a week. And so I think, you know, it makes sense that most people with rebound high pressure will see elevations in their pressure and symptoms for about a week before it starts to, you know, before it goes away. But we also, you know, there are some other possibilities too. One idea is that when you do an epidural blood patch, you increase the veins in the upper part of the spine, because you're basically compressing the veins down low, and that causes engorgement in the veins in the upper part of the spine, and that leads to a stiffer venous system. And then finally, there's a belief that some patients may have pre-existing but unrecognized high pressure that caused them to start leaking in the first place, and that when you go in and seal their leak, they go back to that state of high pressure, but the abrupt transition to that high pressure makes them symptomatic in a way that for some reason they weren't before. Again, we don't know for sure. These are theories, and I think there's a lot of interest in why this occurs. And so finally, I'm going to talk a little bit about how we treat it. And again, this is sort of the broad strokes of my approach to how I deal with different levels of severity of rebound high pressure. So again, I think it depends on whether or not the symptoms are mild, moderate, or severe. And certainly on the mild end, these are cases that are likely going to resolve very quickly. And so what we do is elevate the head to about 30 degrees. I tell folks, go home, prop yourself up on a couple of pillows if you start to get the rebound high pressure symptoms, and just use sort of over-the-counter analgesics. So typically acetaminophen or Tylenol is what I typically recommend, because after a blood patch, we tend to ask people not to use non-steroidal medications like ibuprofen or naproxen for the first week or two in order to let healing occur. If symptoms are more moderate, then we'll add some medication. And typically those medications are going to be carbonic anhydrase inhibitors like acetazolamide or methazolamide. And these are both pretty effective medications that are sort of the first line. What I will typically do is send people home with acetazolamide, tell them to take 500 milligrams at night if their symptoms begin to come on, and then take 250 milligrams the next morning. And then I usually call them the day after the procedure, and we make a plan for what to do at that point. I should also say that because nausea is a frequent side effect of rebound high pressure, I think it's also important to treat nausea. So we send people home with antiemetic or anti-nausea medications. And then in rare cases, we'll encounter severe symptoms. This is, sort of your 10 out of 10 headache. And when this occurs, fortunately, it's pretty rare. But if you can't get it under control with medications alone, sometimes we'll have to do a lumbar puncture on an urgent basis to actually remove fluid, drop the CSF pressure immediately, and then make sure that patients are continued on higher doses of acetazolamide or methazolamide. And most of the time, a single lumbar puncture will do the trick. I have had on a couple of occasions patients who had to be admitted to the hospital and get, serial lumbar punctures over the course of 3 or 4 days before the high pressure started to wane off. Unfortunately, as I said, those are rare. I think these medications, the acetazolamide and methazolamide, do have some side effects. And so whenever I'm starting patients on these medications, I talk to them about some of those side effects. And some of the more prominent ones that people will feel will be tingling at the tips of the fingers, toes, and around the lips. That's very common. It's not dangerous, but it can be unpleasant. And knowing why you're getting that sensation, I think, is important. People will often notice a change in taste on acetazolamide. Particularly carbonated beverages will start to taste quite unpleasant, often with a metallic taste. So making people aware of that is important. Fatigue or nausea or just sort of low-grade GI distress are common when taking this medication too. And then finally, for patients, particularly if they're going to be taking them for longer periods of time, or if we're starting them on methazolamide, we want to make sure that their potassium levels are staying normal. And usually for a short-term basis, I just tell people to make sure to eat potassium-rich foods, have a banana every morning or something like that. Sometimes patients will start them on one of these two medications, like acetazolamide. They'll have some side effects, and we'll switch them to another medicine like methazolamide, and they'll have fewer of those particular side effects. So sometimes if you're having those side effects, just changing up the type of medication can be helpful. There are a variety of other medication options that are used, although far and away, acetazolamide is I would say the first line treatment that's used in most places. You can have medications that have other effects on carbonic anhydrase. like topiramate. Topiramate can also have other anti-headache effects, and so can be another medication that can be tried. Just like in treating with patients with high pressure IIH, idiopathic intracranial hypertension, sometimes diuretics are used, most commonly furosemide, or Lasix is the trade name. Anecdotally, I've had some patients report improvement with medications targeting sort of more neuropathic pain, like nortriptyline, or gabapentinoids, gabapentin is probably the most common one. Lyrica is another one. And then some patients will have reported to me that they've used dietary supplements like dandelion tea. Dandelion tea is a diuretic, a mild diuretic, and so may have some effect in some people, particularly if their symptoms are mild. I want to emphasize that there is little to no published evidence on any of these medications for this particular indication, and so sometimes it's a bit of trial and error. Other things that can be helpful if patients are having trouble at night, elevating your head on a wedge pillow can be very helpful, and those are commercially available. And then patients have anecdotally mentioned to me that a low salt diet can be helpful as well. One other common question that comes up is, what do you do in the case of a sulfa allergy? Because many of these medications are sulfa derivative drugs. But most of the time when people have sulfa allergies, they're allergic to sulfa antibiotics. And there is some published literature that patients with antibiotic sulfa allergies have a very, very low risk of cross-reacting to some of these other medications like acetazolamide. And so generally speaking, in patients who have sulfa allergies, I will usually start them on acetazolamide anyway. Sometimes I'll have them take a Benadryl or something with the first dose or prior to the first dose. But I've never had anybody actually have any cross-reactive allergic reactions. And so I think that's a reasonable decision to make. So in just a second, I'm going to wind up this talk, and we're going to move on to the panel discussion. I think, you know, one of the aspects about this condition is that there's a lot of open questions, a lot of work that needs to be done to optimize treatment for people who develop rebound high pressure. And I think that includes some of these important questions, like what are the criteria that we use to assess whether patients have rebound high pressure? You know, if you're an individual patient, this may not be so important, but you know, if you're in the medical field and you're trying to understand, you know, how many patients get rebound high pressure, who gets rebound high pressure, having a common language where we can say, this is how we make the diagnosis is really important. I think understanding what are the risk factors for either severe or prolonged rebound high pressure is really important, because obviously these are the patients who suffer the most, people who have had symptoms for a very long period of time. And so determining, you know, what puts people at risk may not only help us counsel patients better, but also may influence how people view the risk of undergoing an epidural blood patch. I think it's really important for us to be trying to systematically assess what treatments work and what treatments don't, including medications like acetazolamide that we consider to be first line just on the basis of our anecdotal experience. We should really be systematically looking at, you know, how effective this is as an intervention. And then what are the effective treatments? What can we do for patients who have prolonged or more severe rebound high pressure? You know, how helpful is it to do a lumbar puncture in the immediate setting? You know, some patients unfortunately will go on. I've heard a couple of patients going on to getting shunts Does that really work? Is that effective? Are we treating people effectively? Right now, we have really no data other than anecdotal information on that. And then finally, I think that what we need to do is increase awareness of this condition among physicians who perform epidural blood patches and perform surgery for CSF leaks, so that they can counsel their patients about what to be on the lookout for, so that they can get early and effective treatment. So there's probably much more to be said, but hopefully that gives you an overview of rebound intracranial hypertension, what it is, how often it happens, why it happens, and how we can start treating it. So,
thank you, Dr. Krantz, for this wonderful, clear, and concise presentation. I think this was very good for our audience today. Dr. Khan, before we dive into these Q&A, would you like to share your experience and your approach on treatment for these patients?
Well, thanks, Yasmin. And I also want to say thank you, Dr. Krantz, for joining us today. It is clear that you have an extraordinary amount of expertise in this area, leading our collective knowledge on this disorder, and it's great to meet and learn from you as well. And that was a very concise and thorough presentation. As Yasmin has mentioned earlier, I'm a chronic pain physician at Mount Sinai Hospital, Toronto. I also did some training with Ian Carroll in Stanford. So my exposure to both treatment of CSF leaks as well as rebound intracranial hypertension started in my fellowship, and I certainly have a caseload of patients that I see and manage over time. I mean, overall, I must say it's just a very unfortunate complication, especially seeing that, the recognition treatment of CSF leaks is often so vague and mysterious in itself, and that when you identify the leak and then go to implement the treatment, then there is another host of potential complications that can arise, such as rebound intracranial hypertension. I think the challenge, as the discussion exists with CSF leaks in general about the diagnosis, also pertains to rebound intracranial hypertension, is how do you actually diagnose it? And as Dr. Krantz went over, it's difficult. And certainly to measure CSF pressure is concerning, especially given that initially, there may have been a leak. So to then go implement a leak to measure pressure is often, less desirable. And so the diagnosis, is challenging, but it's a clinical picture. And what I mean by that is that, does the story fit? Did they have a leak? Did you do intervention? Did the characteristics of the headache change? It is in keeping with what we understand about rebound intracranial hypertension. And that clinical picture then, results in changing the management strategy, which often is in contrast to low pressure from the CSF leak. As a physician, we like to be guided by evidence, and that's studies that have shown a drug to be effective or non-effective. Certainly, as Dr. Krantz alluded, in this area, there's just very little studies done, if any. And this is often the case in general, to be honest, in chronic pain itself, across many pain disorders. I think we try to glean data from other related disorders, such as idiopathic intracranial hypertension, that not necessarily was a result of a CSF leak. And there's some, therapies that we use and have had some pretty good trials in that area, as well as migraine therapies. And then there's a host of novel interventions as well that are based on preclinical data that we've been starting to use. So I'll stop there and in case Yasmin has some additional specific questions.
Thank you, Dr. Kant. Yeah, so I think I see from the Q&A questions. There's a couple of questions actually in regards to the acetazolamide for the panel here. First of all, there's a question about how quick you would expect effect of the treatment with acetazolamide. Does it influence the self-regulating mechanism of CSF, and thereby do we run a risk that the body itself is no longer able to adapt to the right level? And therefore, is there a long-term use of Diamox? Is it harmful? 3 questions.
Yeah, so let me see if I can address those one at a time. So the question of how, what's the onset of acetazolamide? I think that that the onset of action does tend to be relatively quickly, within at least an hour or two of taking the oral form. We also will sometimes administer IV acetazolamide. So for instance, if a patient starts to develop symptoms of rebound high pressure immediately after an epidural blood patch, we'll administer IV acetazolamide, and that tends to actually be pretty effective. The second question is an insightful one, because we often talk about acetazolamide as having this effect on the formation of cerebrospinal fluid, but acetazolamide actually has a variety of other effects as well. It's known to be a potent vasodilator, for instance, of the blood vessels in the brain. It has some anti-headache properties as well. And so we don't know exactly what it is that's responsible for those early actions. I would say that in general, if you're going to use it, my anecdotal experience has been that using it on a consistent basis is better than using it on an intermittent basis. So trying to use it, only as needed, I find is a little less effective than using it consistently. In theory, the production of cerebrospinal fluid is driven by your physiology in terms of your venous pressure, your venous blood pressure. And so if you stop using the medication, the CSF production should just be returning to normal and be governed by that physiology driving your venous pressure. I don't know of any evidence that there's long-term disturbances to CSF pressure by using acetazolamide. So like I said, we don't have long-term studies, but I'm not aware of anybody who has had long-term complications.
And do you have any recommendations on how long you would prescribe this treatment?
So I can tell you what I do, and it depends a little bit on the severity. So for people who have mild rebound high pressure, again, I generally don't prescribe any medication, or I don't have people start medication, and it tends to go away pretty quickly. If somebody has sort of moderate symptoms, generally what I'll do is I'll have them on it for a week, and then at the end of the week try to have them taper down by dropping 1 tablet per day. So if, let's say, they're on 500 milligrams in the morning and 500 milligrams in the evening, it's 4 tablets. I'll have them drop one tablet a day, just to sort of ease off the level of support that they're getting from the acetazolamide, and make sure that they're ready to come off. And then if they have persistent symptoms, and put them, go back up on the dose and try again in another 2 weeks or so.
Just to add a bit of my experience as well, I mean, generally quite safe medication, and not aware of any major long-term complications associated with it. Certainly with the potassium, effect on potassium, if you're on it for a serial amount of time, then rechecking electrolytes would be appropriate. Certainly in the cases that are mild or moderate, and the majority of cases that are self-limiting, period of time of being on it safe. I have a few cases that have been on it for years and continue to be on it. And yeah, we just recheck some basic blood work, electrolytes every so often to ensure those are okay, but generally quite a safe medication.
I should also mention that I have seen a couple people develop kidney stones. So if you're taking one of these medications and you have flank pain or blood in your urine, anything like that, you need to let your doctor know about that.
Okay, thank you. Another question from the Q&A is like, how do you diagnose the rebound hypertension? Is it only based on symptoms, or do you do extra examinations?
Yeah, I think Dr. Khan touched on this a little bit earlier, and I would tend to agree with him that lumbar puncture to make the diagnosis is not something that we would do. I think it is predominantly a clinical diagnosis, sort of in the same way that like post-dural puncture headache would be a clinical diagnosis. This is also a clinical diagnosis. I think that we published a series, some of our first cases with rebound high pressure, and in some of those cases, the absolute pressure of the CSF was elevated, up to 30 or maybe even higher than that, centimeters of water. But in some cases, it was not elevated. And therapeutic removal of CSF improved the patient's symptoms. So I don't think knowing a single number will give you the diagnosis. And so if you do a lumbar puncture and you get a number that's 20 or 22 or something like that, it's really not particularly helpful. So it's not something that I would do unless somebody's symptoms were severe and you really wanted to do a therapeutic lumbar puncture at the same time.
Okay. Is there any data out there about these patients where a therapeutic spinal puncture is done to reduce the pressure, and how many of these patients actually develop a leak again, or like hypotension?
Very little data. I would say that if you're having 10 out of 10 headache and you think it's attributable to rebound, I would say that calls for an intervention, and I don't think it would be. I think the risk, people are naturally, if you have a CSF leak, you're appropriately going to be gun shy about having someone do a dural puncture. But at least in spontaneous CSF leak, the risk of dural puncture is pretty small. If there's some potential benefit. So if it's diagnosing your spontaneous leak or treating your rebound high pressure, I think that overall risk is small. We published a series of just a handful of patients, a half dozen patients or so, maybe it was 8. And none of those patients had post-dural puncture headache, but that's a pretty small number.
Mm-hmm.
Another question from, sorry, Dr. Khan, go ahead.
I was just going to add, I mean, in not a rebound, but like in the idiopathic intracranial hypertension literature for, so they use like VP shunts that will put into some patients to drain fluid over time. And I mean, that longitudinal data, at least, it's a separate patient population. It's not very good in terms of long-term data. Like the VP shunts tend to, sorry, I'm in the hospital, tend to kind of poop out over a few years. So the long-term benefit of them is poor. Yeah.
Okay. We have a question from Dr. Lay, neurologist at the Headache Clinic at Women's College, asking, do any of the panelists have experience with the diabetes or obesity drugs, GLP-1 agonist drugs, such as semaglutide, in reducing intracranial hypertension? Some UK research suggests it could be effective. Thank you.
Yeah, so I can discuss that. So this is a kind of more of a novel, early area of utilizing these drugs for potentially reducing CSF pressure. And these drugs in themselves, so GLP-1 receptor agonists, have actually been a class of medications actually been quite remarkable. Initially, helpful in helping manage blood sugars in diabetics, and then finding to be very potent and effective agents at reducing reducing weight. So highly prescribed now for that reason. And in those studies, what was interesting that they found is that, and one of the most common potential side effect is actually dehydration. So actually, in the kidneys, what these drugs have tend to do is reduce the reabsorption of sodium in the kidneys. So there tends to be sodium loss and a diuretic effect, so losing water as well. And this same transporter in the kidneys is responsible for this effect is identical to the transporter in the choroid plexus, which is responsible for producing CSF in the brain, but in reverse shape. So a few very intelligent people thought to explore this, mostly in preclinical animal models, and was shown to be very effective at reducing CSF pressure. I think it was like after the first single dose reduces pressure by 65%. And so there's little human data, if any. There is supposedly an RCT that's underway on clinicaltrials.gov, and so we eagerly await the results from that study. But we'd explored this in one of our patients. So we used actually we consulted one of the endocrinologists who's been using these drugs for weight loss on terms of how to prescribe these drugs, which was new to me. And we used semaglutide because also there's oral form of this medication, which is a bit more mild. One of the main side effects too of this drug naturally is weight loss. So the oral form is associated with less effect on weight, which is desirable if there isn't over a weight issue. And in fact, I mean, going to again idiopathic intracranial hypertension, if there is obesity, if there is overweight, weight loss itself is a good lifestyle change that has been shown to be helpful reducing CSF pressure. But anyways, in this case that we've had, and this is a patient who developed rebound intracranial hypertension post blood, fibrin, and surgical repair, and it suffered from rebound for many years. And we've trialed essentially every option under the sun. And so this was kind of, in keeping with our management strategy of trial and error, we tried this medication and it's been highly effective. Essentially about 90 to 95% improvements in overall symptoms, and has been able to titrate down a higher dose of cetazutamide. So now kind of using it on an as per needed basis. So definitely very encouraging, but something I say with caution because it's a single case, and we have to be guided by clinical studies, which are placebo controlled, to determine, to isolate independent effects of a drug, and definitely, encouraging data like this, support future investigations on this potentially effective drug. But yeah, there's some, I do think there's something there that needs further exploration.
Sounds like a very promising treatment, but we were definitely looking forward to hear more research and more data that's coming out. A few more questions before we wrap up this session. There was a question about if there's any data that suggests that blood patches with fibrin glue result in a higher incidence of rebound intracranial hypertension compared to glot-only blood patches. It's an interesting question.
It's an interesting question. I'd have to go back and look at the data, the raw data from our our look at 150 patients. I believe the answer to that is that we did not find a difference between fibrin glue, and anecdotally, I can't say that I have noticed a difference, with the one possible caveat, and that is that one thing that we know puts you at higher risk for rebound high pressure is a treatment of a CSF venous fistula. It's and if you are getting those treated with fibrin glue, then you might be at a higher risk for that. So I guess it depends on how CSF venous fistulas are being treated. When at your local institution, because there are different options now for treating them. But that would be more of a confounder related to the type of pathology that you're treating rather than directly from the fibrin glue itself. So there's certainly not deep information on that, but not to my knowledge.
Yeah.
Thank you. Is it possible for a person to have high pressure and a leak at the same time and experience highs and lows throughout the day?
That is a great question. And this is something that I hear a lot, is that patients who will say that they alternate back and forth between high and low pressure. I think I've heard that enough to know that the experience of the headaches changes for these patients. What does that actually mean in terms of the physiology? Well, it's a little less clear. I think you can have elevated CSF pressure and be leaking, because I've seen patients with elevated CSF pressure be leaking. But to have rebound high pressure and to be leaking at the same time, I don't know. I think there's a headache specialist in the UK, Manjit Mathur, who's suggested that maybe we should just be calling these rebound headaches, because we don't actually know that the pressure is elevated in all of the cases, and it puts an undue emphasis on actual CSF pressure. And it may not be a pressure issue. It may be a compliance issue. Things are too stiff as opposed to absolute changes in pressure, so that activities or even just sitting upright causes, a sensation of high pressure, even if the absolute measurements are not going up. So I think there's a lot that we don't know. I don't think that it's likely from a physiologic standpoint that people are cycling between actual high pressures and actual low pressures on a frequent basis. I do think that there's something that's causing that sensation because enough people have reported it. I just don't think it's actual pressure measurements.
Okay, thank you. Would you have any recommendations for or against high intensive cardio or doing sports while you're diagnosed with intracranial hypertension?
These are very interesting questions. My take, and interested to hear Dr. Kranz's take on this. Certainly, it should be taken in view of the context of the entire patient itself. Especially considering the possible cause of the CSF leak, presumably initially, and so if there was a spontaneous leak, maybe from a connective tissue disorder or an osteophyte or some type of spinal abnormality, engaging in high impact or rigorous exercise, those would I would consider risk factors as predisposing to another leak. And so I think those type of considerations should be weighed in. Specifically in rebound, with activities itself can increase pressure, and certainly symptoms can be aggravated in the context of exercise. So usually what I say for patients is to have a graded engagement into exercise, to work with somebody to help tailor that as well. If you're walking or cycling 10-15 minutes 1 week, slowly go up over time and evaluate your symptoms in response to that, so to have much more of a tailored and graded escalation in activities over time. But yeah, definitely should be advised kind of taking the whole picture into view.
Yeah, I think I would definitely agree with that there's a lot of factors that go into that might influence the answer to that question. But just speaking broadly, I think Dr. Khan makes a good point that why you have rebound high pressure and how long that has been how long it's been since treatment is important, because you don't want to do something that's going to precipitate a leak. If you've been treated for like a spontaneous leak, for instance, you don't want to do something that's going to put you at risk of recurrence of the leak. But on the other hand, I also feel like, we shouldn't be encouraging patients to do nothing. I think deconditioning is a big problem. Deconditioning can lead to dysautonomia. Dysautonomia can cause orthostatic headache that can be very difficult to disentangle from CSF leak. And I've seen people develop POTS, for instance, while in the process of recovering from a CSF leak, thought to be due to deconditioning, because they're just very, very conservative in terms of what they're doing. So I guess I would say high impact, high intensity workouts wouldn't, broadly speaking, be the first thing I would suggest. I would suggest, good aerobic exercise, walking, maybe a recumbent bicycle, as Dr. Khan very nicely put it, a graded return to that. But maybe not, kickboxing and bull riding and bungee jumping, things like that.
I can imagine that should have to wait a little bit. Maybe one more question. There's a few questions actually about any correlation between hormonal imbalances and the risk or interference with treatment of intracranial hypertension. Any takes on this?
Depends on what type of hormone imbalances.
Let me double check what's here. So any like intracranial hypertension, PCOS, MCIS, possible correlating with hormonal imbalances. Is any CSF leak experts tracking hormonal data?
I would say if you're looking for data, the answer to that will be no. There's no data. A lot of, even when you think about the basics of this, there's really no data for the very most basic things that we do. So there are anecdotes and there's clinical experience. And I think, one of the things that we want to do as a field is move towards better data, and trying to answer these questions a little more rigorously. I think it's one of the best things about the past 5 years with regard to this condition is that there are a lot more people engaged in this question right now, way more than there were 5 or 10 years ago. And that means there's a lot of bright minds thinking about these questions, a lot of interest in trying to answer these questions. And so we don't have the data now, but I would anticipate that 5 years from now we'll have more data than we have today.
Yeah, and maybe like collaborating and sharing databases might also improve and our knowledge, right? Sharing knowledge. I'd like to thank both of our panelists today for dedicating your time and sharing your experience and expertise with all of us. I'd like to thank the audience for joining this webinar today and for asking so many interesting questions. A big thank you to the organizing committee and of the Spinal CSF Canada, both two wonderful ladies who do all of that they can to push this forward and bring this, continue to bring this under our attention. I'd like to say one more thing, that if people are there, if you want to help a charity, please go to the website. There is a link to donate if you feel interested to do so. It will be very helpful. Thank you again to everybody. I wish you a wonderful night, and we'll see you again on our next webinar. Thank you.
Thank you.